Today. We are going to be doing a data analytics topic on applying data analytics to answer questions and solve problems. My name is Brandon Olson. I'm the director of our Master of Science in Applied Data Analytics, and I'm a professor here in the Computer Information Systems Department. And with me today is our presenter, Niall Klyn. And Niall is, and I'll let him introduce himself further as we get going here. But Niall is an adjunct professor in our Master of Science in Applied Data Analytics as well. He teaches our Applications in Data Analytics course. Move to next slide. Thank you. So just a little bit of background first. The College of St. Scholastica, we're a Catholic Benedictine institution founded back in 1912. And the college focuses on several Benedictine values: community, hospitality, respect, stewardship, and love of learning. Those are important values to us. And next slide. And we are part of the, so this is part of the Stender School of Business and Technology webinar series. The Stender School of Business and Technology has programs in management, marketing, computer information systems, health information management, and then our graduate programs in data analytics, health information management, health informatics, project management, and our MBA in leadership and change. All right, so with that, at the end of the presentation, I'll be here with our recruiter, Joe Rembowitz. So if you have questions about the program or about how to apply for any of our programs, Joe can answer those questions. And if you have questions about the presentation as we go, feel free to use the chat at the bottom here, and you can ask questions that way. And you don't have to hold your questions to the end. And then if you use that chat, I can pose the questions to Niall so that he can answer them in that slide. So with that, go ahead, Niall.
Yeah, thanks very much, Brandon, and thanks, Eric, for helping coordinate, and all of you for joining us today. My name is Niall Klyn. I'm the data scientist at Essentia Health here in Duluth. We're a decent-sized healthcare system spanning northern Minnesota, northern Wisconsin, and North Dakota. We've got a bunch of hospitals, a bunch of clinics, long-term care facilities, and whatnot. As I said, I'm the data scientist, and I'm housed in the Information Services, IT, basically, department of Essentia. And so I'm a part of a shared service. So I work with clinicians, I work with finance, I work with HR, quality, the whole gamut, which is one of the great things about my job, right? I get to do lots of different things. I get to learn about lots of different things. And today, I was asked to speak a little bit about using data to answer questions and solve problems. And there's an endless array of things that I could have chosen to talk about today. You know, we could have talked about it really abstractly and sort of best practices and whatnot. But for me, anyway, it tends to be a lot more useful to come at something from sort of a worked example. And so the example that I wanted to talk about is relating to some work my department has done. So again, I'm in information services, and within that, I'm within enterprise analytics. So we do analysis and create analytical tools for everyone in the organization to use for different purposes. So one of the areas that, one of the projects we have been working on now for several years relates to the opioid epidemic. Now, I'm sure you're all aware of the opioid epidemic, that it is a nationwide problem. It is absolutely a problem in the populations that we serve. We have lots of people who are addicted to opioids. We have lots of overdoses and misuse of prescription opioids. So this is just a slide from Health and Human Services. It's a little grainy now. I apologize for that, and call out just a couple of numbers from this from 2019. So 70,000 deaths, almost 2 million, 1.6 million with an opioid use disorder, 1.6 million misusing prescription pain relievers, and 10.1 misusing those prescription opioids in a single year, right? So this is an absolutely massive, massive problem. And to be honest about it, from a an analysis, analytical perspective, it's an interesting problem because it has a lot of different factors that go into it and a lot of different things that you need to think about. So given that this is a nationwide problem, just right off the bat, you should be thinking, I tend to think, I guess, when I consider it, that any one system, any one person isn't going to solve this all by themselves, right? So as I get into what we do at Essentia and the problems we've been tackling at Essentia, recognize that we're working within these broader systems and within these different ways of trying to tackle this problem. And we're only one component, but it's an important component, right? These prescriptions have played a really large role in propagating and creating this epidemic over time. So from our perspective, from an Essentia perspective, the problem that is thought about at the system level is, well, we want to improve opioid prescribing. And sort of implied in there is that it's more of a goal. Implied in there is that there's a problem that there's too much opioid prescription, that we want to use it only when it's needed, do not use it when it is not needed, and specifically when we do need to prescribe an opioid for pain management, that we only prescribe as much as is necessary to help the patient manage their pain. So that's not something data is going to answer all by itself, but we need data in order to be able to affect this change. Specifically, from the start, we need to know how much we're prescribing. And unfortunately, just like pretty much every other organization I talk to, it's not all set up. The data is not all set up that you can just go in and grab that metric right off the bat, right? This needs to be pulled together and collated and figured out from all of these different data sources. And I'll get into that a little more in a couple of slides. For the purpose of this talk, I do want to focus this in on prescribing around surgeries and procedures. So there's a whole separate effort on opioid prescriptions in chronic pain management. I say it's separate. It's a lot of the same team, but the data and the analysis we're doing are very different, because again, that is meant for sort of long-term use, and this is supposed to be prescribing around a short-term post-surgery to help manage the pain from that surgery. So that's really where we're going to focus in for the rest of the talk. Now, when we talk about how much we're prescribing, one of the useful ways to think about analysis problems can be in sort of divvying it up into buckets. Now, this is a graph. I grabbed it from Gartner. You'll see thousands and thousands of graphs that you can grab. And, I do a lot of programming for my work, a lot of coding, and a core principle of coding is, don't do it if someone else has already done it better. So here, instead of making my own, I grabbed from Gartner. So just making sure to give attribution there. But we're breaking out analysis into a couple of different buckets. And those buckets generally are descriptive, diagnostic, predictive, and prescriptive. And you'll commonly see it in this sort of ascending chain, where on our y-axis, we have value. How much value is the analysis adding to the business or the organization? On our x-axis, we have difficulty, meaning how hard is it to complete this analysis? And you can see the idea here is that descriptive is lowest value and also lowest difficulty. Going up the chain, diagnostic, why did it happen? Predictive, what will happen? And prescriptive, this has the how can we make it happen? A lot of times it's more like, what is the best action to take given your analysis? Or sometimes even further, making the decision based on the analysis without a human in the loop sometimes. That really gets into that optimization idea. So this is a useful sort of heuristic to think about this. And you can think right off the bat that, all right, our first question with the problem is just how much are we prescribing? We're very much in that descriptive bubble. But that's probably not going to be enough, right? We're probably not just going to look at how much are we prescribing and say, all right, we know what we need to know to take further action. So maybe we're going to move up into that diagnostic. Maybe even there's a role for predictive and prescriptive, and I will cut to the chase for the purposes that we're not getting all the way into predictive. I can touch on how we're using some of that, but that's not going to be the focus. We're going to stay more in those first two bubbles. And even though those are supposedly lower value, I'm a big believer in the idea that you should use the right approach for the question at hand. So even though my role focuses on advanced analytics, predictive models, natural language processing, artificial intelligence, all of the buzzwords, right? I'm not going to take us there if it's not adding any value to the question at hand. And again, the question right at hand is, what happened? What have our prescriptions been? So this is one way of looking at it. There's one other way I want to show you, and here I got from acvo.org of bucketing these out. And the reason that I wanted to call this out is that we have these buckets of descriptive, diagnostic, predictive, and prescriptive. The first is that it doesn't explicitly say it's less valuable, which I'd like, because again, sometimes descriptive is the appropriate level of analysis, sometimes diagnostic is, sometimes you need to get to prescriptive. But it does recognize that at those different levels, there are differing amounts of human input needed before you can make a decision and take an action. And it does typically, but not always, fall in this sort of category where descriptive is going to take the most human input, further thought, further conversation before reaching a decision and into an action. Whereas we can get down to prescriptions where we automatically make decisions that cause actions. And you can think of things that you do interact regularly with, optimized routes for an Uber ride or something like that, where that decision is sort of put into the system right from the algorithm. So we know that we're in the descriptive space. What are some of the things we need to start thinking about right off the bat? Well, as I said, we need to start thinking about bringing the data together. We use an EMR for our clinical records. We use Epic as our EMR, and we have data, as we're thinking about prescriptions, we have data in hundreds of different tables just for this one question. We need to start thinking about bringing them together. How can we tie the right prescription to the right encounter, to the right provider, to the right patient, to the right surgery? Because that surgeon may not have been the person who made the prescription that's relevant to that surgery, right? That may have been a different provider. What's the right granularity for this? And when I'm talking about grain, I'm talking about what is each row? If you're thinking about it like a spreadsheet, which is a totally fine way to think about how we're bringing these data together. If you think about each row of the spreadsheet, what does each row represent? Is it going to be a provider? Is it going to be a patient? Is it going to be a surgery? Is it going to be an individual prescription? What does that granularity need to be? And that's going to influence how we bring those data together. Then one of the things we need to start thinking about, and as a team, my team does a really great job at working on, is how are we going to consume these data? How are you going to, going back to our previous graph, how are we going to take action off of this? How are we going to make decisions off of these data? And depending on who is doing it and how they're going to make use of it, we might make different choices about A, bringing the data together, and B, what tool we use to present the data and the analysis. So as I said, we have Epic as our EMR. We have options for creating analysis and visualizations within Epic. And if we're focused on clinicians making decisions in the moment, we probably want to bring it into Epic for them because that's really where they live and do most of their work. If we are looking at operational or executive leadership and that sort of process, and we are okay with some latency, meaning the data might be a day old or 2 days old or 3 days old, typically less, but then we might bring it in Tableau, which is a visualization tool we use for a lot of our storytelling. So we start thinking about how to consume and how it's going to drive decision and action right away, right at the start of the process. And then the last thing we need to start thinking about, not the last, one of the other things we need to start thinking about are the statistics. Now, when I'm talking about statistics, I am talking about the sort of single thing, the single number you're going to use to represent a lot of different numbers. I'm not talking about inferential statistics. I'm not talking about the classes you might have taken in college. I'm just talking about things like mean or median or standard deviation or interquartile range, right? These sort of very short summaries of a big amount of information. And the reason that's important is because when you're talking about how much did we prescribe, and in fact, I participate in these conversations a lot. Frequently, the question is, what's the typical prescription for this one surgery? And I'll say, what do you mean by typical? And they will say, well, like what's the average? Now, average has a really specific meaning, right? Average, the vast majority of the time when someone says average, they're talking about the arithmetic mean. Right, that's the average we're all familiar with. It's A plus B plus C, over 3 in this particular example, and that gets you the average. And it is what we're frequently asked for. And part of the role of the analyst is to say, okay, hold up, is that actually the number you want? Is that how we want to estimate the prescription, the opioid prescription for this particular problem? And the reason for that you need to push back sometimes on that is for reasons like what you're looking at right here. So this is a histogram. It's made up numbers. These could be anything. This could be, morphine milligram equivalents, MMEs. This could be, number of users on a website over time, whatever. It doesn't matter. And then we take each one of these values and we count how many times it appears in our overall data set. And we use that to make the bar. And again, this is just called a histogram. You also see density plots, things like that to represent these data. So what you're looking at here is, all right, we've got this large peak down in these lower values. And then we have values, you can see the break in the x-axis here, all the way up to 500 in this particular data set. So if I take the mean of this particular data set, if I'm using the average, that is the average. It's around 4, just shy of 4 is the mean for this constructed data set. That mean is greater than 75% of my data. So is that a useful estimate for this particular data set? And I would argue, obviously, no, it's not. Maybe something that would be better is something like the median represented in this red line. I kept the mean there in blue. And the median is, of course, that 50th percentile. It's really the middle of the data set, and it's not influenced by those outliers. However, maybe those outliers are important. It depends on what you're trying to do. So you need to start thinking and having conversations with the folks who are going to be consuming the analysis about what's most meaningful. What are they going to be able to act on? And how is it going to inform their decision-making process? So histograms can be a useful way to look at it. Another way that you might see are these, box and whiskers plots, where you've got your 25th percentile and 75th percentile encapsulated by that bin. So it's a little easier to consume. It also gives you the mean. It's a little easier to consume than the histogram, and also gives you a sense of some of those outliers. Again, with a data set like this, where we go all the way up to 500, it's going to be important to call out the outliers as something that's in the data set. Do those represent useful information? Are they mistakes in the data that should be corrected? Or is it, truly something that needs attention? Is another thing that will come up through this process. So for our data set here, when we're looking across all of the prescriptions, this is what our histogram looks like. It's not terribly dissimilar to the one I showed you before. It's not quite as focused down in those very, very low, but we still have a really large crest here in the lower values, and then we have values all the way out almost to 600. You will notice, however, that they are so small relative to our y-axis that you can't even see them. So when I pull for this particular data set, when I pull the median and the mean, they're actually very close together. A lot of the weight is in these lower ranges, but it is important for our team and our deciders to know, we've got ranges from just above 0 all the way out almost to 600 MEDDs or MMEs, depending on how we want to slice and dice the data. Quick note there, that's an MEDD, that's the morphine equivalent daily dose. It's a commonly used metric to compare across opioids. The other common one that you'll see, I think, in some other slides is a morphine milligram equivalent, MME. I can't get into the details on those because I am not a clinician ultimately. So as we start to have this initial answer, like, okay, how much are we prescribing? Well, this much. This is how much we're prescribing. It's not necessarily that useful. Even if we went to them, gave them the median or gave them the interquartile range from that previous slide, it's not enough to really take action yet. And so we're starting to have conversations at this point in the process of, all right, well, we need to make apples to apples comparisons. We know for sure that we're going to be prescribing different amount of opioids. If you're having a knee surgery, depending on the type of surgery, then dealing with, you know, a broken arm. You know, all of these surgeries are going to have different ranges, and it really makes the most sense to compare or to look at individual procedures. Then, as I said, you know, how are we going to equate across those different medications? Happily, that's not something we had to solve. It's just something we needed to find in the literature, and our expert clinicians already knew all of this information, so they were just telling us, and we were making sure that we were making those conversions in the data properly if it wasn't already built into our Epic instance. Meaning, if it comes in from our data set as, you know, they were given 500 milligrams of medicine X, that works out to be how many MEDDs, how many MMEs over what period of time. One of the other problems we see as we pull in these data, again, is that problem of provider attribution. Who should we say this prescription is relevant to? Should it just be relevant to the surgeon, or should it be relevant to the person who made the prescription? Ultimately, who is accountable, and how are we going to make decisions and affect that kind of change? So let's start pulling out and breaking out, as we do this analysis, let's start breaking out some of the information from that big histogram across all of those different procedures. Here we're going to pull just one procedure, and then we're going to break it out by different locations. Maybe this is a way that we can start thinking about getting to a decision and getting to an action based on prescribing habits. Now, I've made the locations so you can't see them. We have our MEDD, this is daily dose. I had the wrong axis there on our y-axis, and we have different locations on our x-axis, and what you're looking at is what is commonly called a violin plot. And really, this is just a histogram mirrored so that you could fit a bunch of them on the screen. So we took it horizontal and made it vertical. So this represents more prescriptions at right around 30. You know, this is right around 45. And you get a sense of these different distributions just from this violin plot. So already you're seeing a lot of variation. You're seeing variation for one single procedure within a location, and you're seeing variation across different locations. So this, whatever location this is, had a high concentration of fairly low dosage, but also had, you know, a fair number that was more than 3 times as high as that lowest prescription. Contrast to this location that's got really strong prescribing habits right around 40, and just a couple up higher, and a slightly smaller amount down around 20 milligrams. So we can start breaking out and getting into some of those ideas of diagnostics, start pulling apart and teasing apart that big number and trying to understand what's happening under the hood here. What is going on with these data that can help us understand what's happening in practice and drive changes in practice over time. Another way of doing it, instead of a violin plot, we might look at a single specialty looking across different procedures, if that might be something that's useful. Here, you know, you're trying to get to a point where you can dig in more to an individual procedure. So here, this vitrectomy posterior with scleral buckle, right? We've got a really strong peak here at our lowest prescription, but we also have some prescriptions at more than twice the dose. We're starting to think, well, what's happening here? What's different about those higher doses? Is it a patient difference? Is it a provider difference? Is it a location difference, different protocol on those prescriptions? Really, what's happening? So as we start to do, I'm sorry, Brandon, was there a question?
Nope.
Okay, sorry. As we're looking at these distributions and as we're starting to dig into the diagnostics, what's clear as we're having our conversations with our operational partners is we're really trying to get at how much should we prescribe? And how are we going to improve our prescribing habits? How are we going to really get at that? Prescribe what's necessary and not what's not. Use them when they're necessary, but do not use them when they are not necessary. And use the least effective dose for getting to across our systems, across our providers. So how much should we prescribe? Well, unfortunately, in this particular case, there aren't existing comprehensive existing guidelines for surgical prescribing of opioids. I'll be honest, that was a surprise to me when we were having these conversations. We were talking to the docs and saying, well, how do you decide what's appropriate? And there's a lot that goes into it, but there isn't one sort of guiding document to help you understand, all right, I'm doing this kind of surgery and my patient is 70 years old. This is how much we probably should prescribe. In general, the principle is simply this: use the lowest effective dose strength. So from an analytics perspective, then, we're getting back to, all right, how are we going to find that from the data that we have available to us? Then the other question was, how are we going to improve? How are we going to make use of these data? As we find these opportunities, as we find these discrepancies, how are we going to make use of these data to improve? And for us, and for this particular application, it was twofold. One that I keep hearing is that doctors are very competitive. And if they see their score relative to other doctors' scores be better or be worse, that's going to add motivation, and that motivation can change habits. I've not done rigorous research studies on that, but that is the sort of some of the change management that exists within the healthcare system. And I'll say Essentia is not unique in that that approach. And the other is conversations, right? So we need data to support conversations between leaders and individual providers in order to guide that conversation into, all right, so here are your habits, here are what we're prescribing habits, here are the prescription habits for others that are like you or have similar patients or doing similar procedures, and guide that conversation to say, all right, well, what's, why are you prescribing more? Or how are you prescribing so little? Is it effective for your patients? Is this something we could take across to the entire department and say, hey, look, I'm using fewer opioids here and having really good outcomes. Maybe others can follow along. So that's, again, getting us to that. All right, so how are we going to make use of this data? How are we going to present these data? So the idea from the team was, all right, we're going to use those outside guidelines when they're available. Not so available for surgical procedures. That is very much the case for the chronic prescriptions. There we have some very discrete guidelines. But for surgery, not so much. We want to make sure we're comparing our individuals to our relevant groups. So not just procedures, but specialties. So if you have the same kind of procedure performed by different specialties, that's probably representative of something that is different in the patients and the encounters that may also lead to a difference in the prescription, and a reasonable and appropriate difference in that prescription. And then from these conversations, the decision was made to, we want to target large prescriptions, meaning high dosage prescriptions, and then somewhat the variability in those prescriptions. Now, I will talk more about that because I think it's an interesting problem, and my meeting right after this one is me to argue that we need to focus in on the variability more specifically in this use case. So what are we talking about here? Going back to our previous slides. All right, so here we want to focus, if we're thinking about those high number that high dosage, I should say, we're going to be focusing in, all right, who's making these prescriptions up in this 80 to 90 milligram morphine equivalent daily dose rate? Can we narrow that down? Can we also look at this variability across these locations and get a sense of, all right, what are you doing differently? What is this location doing differently than this location? Not just in prescribing, but how are they using other techniques to manage patients' pain? Or are the patients super dissatisfied at this location and feeling like their pain is not being handled appropriately, right? All of these things we can start to dig into once we find that as an opportunity within existing data. And the same idea here, what is happening at these upper ranges compared to these lower ranges? Is there a functional difference? So going back to our where are we? So we're getting into a what happened and now really moving into that why did it happen? What is the difference that is driving? What are the differences in process and patients and procedures that is driving these differences observed in the prescriptions? How can we use that and the human input in order to make different decisions and change our actions? So this is a snapshot of a Tableau dashboard that is currently in use, currently being revised. As I said, I'm going to go into a meeting right after this one to argue for some changes in this. to help us find some of these opportunities and allow us to dig into our data in order to get at change in opioid prescriptions across Essentia. And I will say this has been very successful, both this dashboard, but also this initiative has been very successful in driving some change in our system. So it's been really great to watch. Do a quick orientation here. So at the moment, I've selected a specialty down here of orthopedic surgery. We're looking across all of the different surgeries and procedures that orthopedic surgery performs over the past year. This tells us the total number of procedures, our overall rate of opioid prescriptions. So out of this 6,000, 83% have had an opioid prescription following that surgery. What is the mean morphine milligram equivalent? And we default here, you see, to that MME. What is the median morphine milligram equivalent? And then the percent at goal for that particular procedure. So those are just those high-level metrics. As I select different things, those are going to reflect those changes. Up here, we have providers that are within that orthopedic surgery specialty. You can see I blocked those out, even though these data are just sort of sample data, aren't real data from my system. I didn't want to call attention to anyone unnecessarily in case it was misinterpreted. But so that's sort of giving that ranking and trying to work into that competitive nature. Oh, I'm at 80% and Dr. Smith is at 96%. And not only that, we've got comparable numbers of surgeries. This is one of those tools that's using us that we are using to help drive those conversations. Here we have the distribution of that morphine milligram equivalent. So this is just like that histogram you saw earlier. Instead of bars, we've got it as that area chart. And then on our right-hand side, we have a bubble plot that is helping us narrow into the procedures. So as I said before, it may not make sense to think about it just as a provider to provider within a specialty. We need to get down to those different procedures. This provider, may be at 96% and this one may be at 80%, but maybe they have a very different case mix of their actual procedures. And so that would not be as useful comparison as if we select it down to an individual procedure. Now, these individual procedures their size is just by the number of cases over this period of time. And then the color is in the overall median morphine milligram equivalent. So darker colors means it's higher. Just to give you a heads up, this is where I think we could improve. One of the areas we could improve this dashboard. I think the color should be guided by the variability within each one, the spread of this distribution, not just the median. Because if I pick this tiny little bubble down here and it's bright red, but all of the encounters are at that same level of prescription, maybe that's not very helpful. Maybe we really need to look for that variability rather than looking for high level of prescriptions or of dosage, or maybe it needs to be both. Maybe we need a combination of the two. So what'll typically be done is someone will come in, they'll decide, all right, we're going to work with orthopedic surgery today. We are going to look and find a procedure, and maybe we're going to pick robotic assisted total knee. So we'll select down to that. And now we are looking across all of our providers, across all of our locations, and we are looking for the dosage across those providers over the last year. So you've seen these values change. You've seen that we very frequently prescribe opioids for this. That is the most effective way to manage pain after this surgery. And we're looking at our distribution. And right off the bat, I'm looking at this and seeing, all right, so we've got quite a few that are below 180. We have ones all the way out to 900 MMEs. And we also have a really large peak at 300. So we've got 180 versus like 300, 310. And there's some differences here that right away I might want to dig into. And we might dig into it by looking at some row level data that I obviously can't show. We might also dig into it by getting down to the individual provider and start having those conversations with individual providers. So who is making these prescriptions? Well, this handy map up here tells us, who is above or below in terms of their relationship of prescribing to the group. So we can select one of those as an option. I had to do some extra blanking out here for us. And so now, in addition to our orthopedic surgery distribution in that area graph, we've got individual lines representing the prescriptions from a single provider for robotic assisted total knee and orthopedic surgery. And you can see we've got a new axis here. So it's not that this one provider is giving all of these prescriptions, but this one provider is dominantly prescribing at around 300 morphine milligram equivalent relative to other providers that are able to do manage their patients' pain, hopefully effectively, at a much lower dosage. And so it's really starting to drive that conversation just from this analysis, saying, all right, what's going on? Maybe there's nothing here. Maybe this provider sees the sort of the hardest patients or the oldest patients or something else that means they needed to manage that pain in a different way than their peers. But it's getting us into that insight relatively quickly and getting us to that conversation in a fast and efficient manner. So as we think about how we make use of these data in this particular example, there's a couple of things I wanted to call out as sort of just backing out to the more abstract. The first is that, just most of the work is in getting that problem well-defined and the actions that are going to be taken based on the analysis that could be taken based on the analysis well-defined is a massive part of the effort. A lot of times people are coming to analysts and saying, hey, I want to know how this works. So I'm going to try and change this. Can you make a dashboard? Can you make a report that's going to help me? And if you just go straight into that and start, whipping out charts and whipping out statistics without real understanding how they are going to drive change and make those decisions based on those data, you are going to spend 10 times as much time backtracking as you would as, just really setting up the problem in the first place, making sure everyone is on the same page, making sure all of the definitions are the same, making sure everyone understands what actions are going to be taken so that you can drive your analysis to those decision points as effectively and quickly as possible. The second is that obviously this needs to be a cross-disciplinary work. I remember when big data started sort of making the rounds as a buzzword, and even in interviewing, frankly, for this job as a data scientist, there was this perspective of, finding these hidden insights in the data that make these revelatory changes. And to be sure that that does happen and that can happen. But the vast majority of the time, change is being driven by cross-disciplinary work where experts in the actions are working with experts in the data to really drive change together. So I could not do the work in opioids, without talking to clinicians, without talking to pain management specialists, without talking to the program coordinators and folks who are really making use of these data. If it was just me saying, hey, look at this provider, who would I be talking to? How would it make sense? It doesn't work most of the time. Most of the time, the productive work is in cross-disciplinary effort. Another one is that analysis is an iterative process. We went through some sort of faux examples here where we built some simple charts and whatnot to look at the data. We take those back to the team, say, is this what you expect? What does this tell you? Is it useful? Does it speak to those decisions and actions that we spoke about earlier? And you come back with another idea. And definitely the most successful analytical products I've seen in our organization are ones where there's a lot of back and forth, a lot of feedback from the users, a lot of different prototypes made by the folks designing the analytical tools and reports, and really getting to something that's useful for everybody. Another one, as I put here, is, maybe don't get a Ferrari if you just need a grocery getter. You could put it a little more easily as sometimes simple as best. So as I said, on that chart of descriptive, diagnostic, predictive, prescriptive, I don't always go straight to the fanciest thing I can think of. Try and understand the problem, try and understand the decisions, try and understand the actions, and pick the right tool for the job. The last one I want to leave you with is that data is not the same as objectivity. right? So everything I talked about today was really focused on the prescription and the provider and the surgery. And I mentioned the patient pain bit several times, but what you never saw on the screen was patient pain. You didn't see that well defined. You didn't see how those different prescriptions relate to the subjective experience of the patient's pain. That matters a lot, right? That is a big part of what we're trying to do here is help patients lead healthy, productive lives. And we can't do that if we're ignoring the patient's perspective. So that's something that needs to be always integrated and thought of. And the other bit is that we are not, just because we have these data points, doesn't mean that we are coming to any sort of objective truth, right? The data points that we find have been filtered, have been decided on, that these are the relevant things that we're going to be looking at. And we ignore all of those data points that don't speak to the initial question at hand, but we made that decision. It's a subjective process to make that decision. And that has consequences for, how you proceed, how you find those decisions, and how you drive action within your system. And the biggest one for me on where this is coming in is into those predictive and prescriptive spaces in this. So one of the things I didn't show you is that we do have a predictive model that relates to the likelihood of opioid misuse or overdose in a patient. And it's critically important when bringing a predictive model like that online to think about how it's going to drive action, right? Is a provider going to look at that and say, oh, there's a high level probability of misuse or overdose. Maybe I need to not prescribe an opioid to this patient, or maybe we need to monitor this patient more closely. All right, well, then now we need to think, it's driving that kind of action. Is it affecting all of our patients equally? Is it set up in such a way that it takes into consideration different socioeconomic constraints and inputs? Is it really getting us to an action that drives health for the entire population instead of narrowly in on those of high socioeconomic status or otherwise? So just things to keep in mind as you're considering those analyses. So I think that's it for me. If you have follow-up questions that we can't handle today, I'm happy to take your questions via email. There's my email, niall.klein@essentiahealth.org. Feel free to reach out. But beyond that, we can move into the Q&A session.
Great. So while we're waiting for questions, when I was typing over there, I was typing my questions here. So I've got a series of questions that I can fill in here until we get people from the audience that also want to pose questions. First question is, when conducting an analysis, what portion of your questions emerge as you go compared to those questions that are defined up front before you begin?
That's a good question. I will absolutely have to make up numbers if I'm going to put a number to it,
Sure.
because I've never done an analysis on it, but now I kind of want to. So I will say the way we have set up within Essentia to handle these kinds of requests, typically there is a guiding overarching question that is put out at the start, and that tends to not change massively over time. That tends to stay relatively consistent. And I have a caveat to that I want to come back to. Then from there, all of the actual practical questions, like getting into this level of analysis where you decide, specifically what your outcome is, specifically what variables you're looking at, those are all generated in that iterative process with the operational owners, with the business owners, with the clinical owners who are going to consume that eventual analysis. So, just numbers wise, it's massively generated after you start. But that first one is really the guiding question, and that, tends to remain relatively steady. The caveat I wanted to mention is that, or a caveat / a plea, which is that to have someone from the analytical team in the room when that guiding question is developed. There are certainly times, it's true at Essentia, it is true at every organization I know of, where there are these questions put forward and the data don't exist within the existing architecture to answer those questions, right? And so, and you don't know that unless you are deep in the data and really aware of what data are available to the organization. Sometimes that just means you go out to an external vendor or whatever and find the data, but sometimes it's not realistic to answer that specific question. And you need to then get at what the goal of that question was and see what you do have available in order to be able to answer it. It doesn't happen a lot, but it does happen.
Okay, thank you. I just sent out a chat posing, asking for questions, but we'll wait. I still have plenty more here. So in your work, how are you connected to the problems? So you're not going and walking around asking people what problems do you have. You know, somehow they find you. How does the organization begin working with you to solve these problems?
Yeah, you know, it's funny that you put it that way, because I was just talking with another leader in the information services in the IT who does go out and ask people what their problems are. And in a way, I have been engaged in that over the last several months. As I said, I'm a data scientist, I'm in IS, we're really building a data science team at this point in time. And because we're expanding our capacity, we're also trying to expand our contact and our relationships with the different parts of the organization. So I have regular meetings with, you know, the folks who lead quality, the folks who lead process excellence, you know, maybe the hospitalists or the supply chain or the finance directors, to say, all right, what are some of the biggest problems you're facing right now? What are some of the strategic initiatives you have at your level of the organization that you are going to be trying to drive forward over the next few years, and understand how the tools we have available to us as analysts could maybe support those initiatives. So that's one of the ways, and that is the way we are trying to drive the more advanced analytics work at Essentia. For more of the reporting, you know, those regular engagements happen as well within enterprise analytics, but a lot of the work comes in through a project charter process where a team or a group or a committee or even an individual will put in what's called an SBAR, basically just lays out the situation, gives some background, assessments, and then a recommendation saying, hey, this is a problem, and we need some support from IS, from IT, to be able to work on it. That gets valued, essentially rated by a committee that says, you know, this is a really big problem, we really need to tackle that. Then that goes through a process of creating a project charter, saying, all right, here's how we're going to tackle this situation, and here's how we're going to try and answer it. So this is where you're going to get at some of those initial, like, all right, are we, like, what data are we looking at? You know, really defining the problem in a written way, so that everyone can see it and agree on it. What kind of tools might we be using to help answer this question, how to solve this problem, and you know, and then scoping in terms of the amount of work it's going to take. And that sounds like a lot. You know, as part of project, you know, that can be two weeks. It doesn't actually have to take that long, or even faster if it's something that's a higher priority. Sometimes it can take a little longer. So for these larger, like the dashboard I was showing you there, that would be very much at that project charter level.
Okay, good. And so Lisa Peterson she's asking the same question I was going to ask her as a follow-up question is, how do you know when you're done with analyzing the data? The iterative process could go on for a long time, I imagine. So just, you know, as you're doing your analysis, more questions emerge. And since this is treated as a project, how do you know when you're done? It seems like you could go on for forever with one question.
That is an excellent question. Yeah, you're right. You're 100% right. There is no, generally, there is no clear stopping point. If all you're doing is following your question and following the different questions that come out of the data. I'm particularly susceptible to that because, you know, I'm curious. That's why I do what I do. And so you see something interesting and you're like, oh, wait a minute, what's going on with this? Let's try and track this down. The good thing about that formal project chartering process is that you define clear endpoints. Like, all right, we're going to get it to here. And then if we find more stuff that we need to chase down, you know, then we need to stop, go through that process again and decide whether it's worth that further investment in time and resources in order to further develop the analysis. It's not a perfect system. It definitely helps to have those clear defined endpoints ahead of time. There are times where those have had to shift, like, oh, the answer we got to is just not going to drive the decision-making process the way we thought it would. We need to follow up on this more thoroughly. And you do get that scope creep at times, but generally that's how we manage it. Really clearly defined endpoints. As we find new things, maybe we'll go into sort of what will be a new project.
Or treat it like a change order, for like a project. As your new questions emerge, you can kind of tack that onto the project.
Yes, absolutely. That does happen as well.
Okay. We still have some more time for more questions. While we're waiting, I have another one for you. So when you present your findings, I assume that you probably do some type of oral or written presentation. How do you handle assumptions and limitations? I guess could you first maybe provide some context of what I mean by that, and then explain how you handle that in your presentations?
Yeah, so that's actually interesting to think about, I think, because the tool that I showed you for the visualization there, Tableau, you'll see people talk about it as a visual analysis tool, or as a visualization tool, and that's true. I think Tableau really excels at telling stories with data. And a lot of times when you're telling stories, you don't focus a lot on the ambiguity or on the limitations, or even on the assumptions that went into your analysis. So I think and this is just my personal perspective on it, not representing Essentia or IaaS or EA or Enterprise Analytics, is that Tableau really kind of does us a disservice there. I think when people consume Tableau products, when they consume those visualizations like the one I showed you, it doesn't always provoke them to think about what might not be accurately represented there. It just, it looks clean, it looks professional, and so you're like, oh, this is what happened. So you asked about assumptions and limitations and some of the background. So I think it's probably easiest for me to speak to that when we talk about some of the predictive or prescriptive modeling that we do. Because there, again, we might make a predictive model. Well, when I was talking about earlier today with some folks, is a predictive model we have for mortality, likelihood of death in sepsis patients. And we use that model primarily for benchmarking. It doesn't drive clinical practice per se. It drives how we compare how our clinical practice has been doing, but it's not by itself, doesn't see a patient in the moment. And it's being consumed in a Tableau dashboard. And, in presenting it, we prepare white papers, model briefs. We prepare a bunch of different documentation that's really focused on trying to help the end users understand everything that went into the model. So that's, all right, here are the data points we look at, and maybe some things that you do that are relevant to those data points are not captured in our system. So that right away is a limitation. Maybe your workflows change, and the model obviously doesn't know that, but it continues to consume those data. And so that's a limitation. There are assumptions that go into the model, assumptions about how different variables relate to each other, or about if they don't relate to each other, and how the end user can, not the end user, how the model makes those assumptions. And if those assumptions are incorrect, the model output is also likely to be incorrect, and it could be incorrect in a variety of different ways. So we have that documentation. Whenever we come up with something like this, I talk to the end users about it, and it is a constant struggle, I think, because it's not super easy to talk about it, as you're noticing right now, for me to talk about it without getting into the weeds. And you don't need to get into the weeds. You just need to understand that there is a lot of variability that's not captured. There's a lot of assumptions that could or could not be accurate. And, it should only be used for certain things in certain contexts. But obviously we're not incredibly successful at it. I think in the end, people tend to look at these things and say, oh, this is accurate or this is inaccurate. And there's often a lot of sort of black and white response to these products and these analytical tools that does everyone a disservice, instead of thinking of them as useful modeling tools. We really focus in on the, oh, it's accurate, oh, it's not accurate. No, sometimes it is, sometimes it isn't. It's always a probability. It's a challenge, and it's one we're continuing to work on, but certainly haven't perfected.
Good. So I've had to call out for additional questions. I haven't had any yet, so I'm going to try one more question, and then we can wrap things up here. So you showed us that useful slide earlier on about the different forms of data analytics. So that would be descriptive, diagnostic, predictive, and prescriptive. What forms do you find most common in your work, and do you see that changing over time? Are we getting more sophisticated with our data analytics?
Yeah, that's another great question. So, I mean, again, just in terms of sheer numbers, descriptive is most common. I mean, you can't get to anything else without the descriptive. It's really going to be the foundational layer to help understand a problem and decide, what else you want to do with it. We are for certain seeing an increase in the predictive and even touching into the prescriptive modeling. There are a lot more tools that are available, and even some of the common tools we have allow you to do some of that analysis without a lot of technical background. And I'm very much of a that's great kind of mindset. I think that's fantastic. As much as we can democratize these tools, I think the better off we are. There are some barriers to implementing those in a productive way. And the barriers are things like we talked about in terms of making sure the questions are well defined so that you're building a model that does what you're trying to do and really helps drive that change. That seems straightforward and isn't always. And then really thinking about sort of the ethical deployment of some of these models. Like I've started to talk to at the end of the talk about what are some of the possible consequences, right? Because those data are collected with all of the standard biases that we bring to the table. Your predictive model and prescriptive models will only be as good as the data they're consuming and will replicate or even accentuate some of those biases. And that's something we've seen frequently in machine learning and artificial intelligence, where we build a predictive model. A really good example is one for an overall risk model that was built by a healthcare organization that relied on data from patients. But what is risk? And so they operationalized that by saying risk is overall money spent in healthcare. That's obviously going to be dependent on your ability to access healthcare in the first place. And so as they made those predictions, they built in unintentionally a bias. And so that's fine. And it was eventually caught, and they switched things out, and people are generally a little more mindful of it. But as we look at those democratized tools, I think we also need to push the ethical deployment side of those easy to use, easy to access tools to make sure that we're using them in an appropriate way.
All right. Well, thank you, Niall. Thank you for today's presentation. It was very informative. Appreciate you doing this for us. And wanted to put out in the chat here too, if you have follow-up questions, I put our email addresses out there. So feel free to copy those. And if you want to reach out to Niall or myself with follow-up questions. But thanks for attending our webinar today. And thank you, Niall, for presenting. And we'll hope to see you soon.